welcome to the Allied Health webinars for this evening, or the morning, or the afternoon, wherever you might be in the world. My name's Georgie Pazimilis, and I'll be facilitating this evening's sessions. We'll be having 15-minute talks by 3 speakers who presented at Cancun World Congress for WFPICCS in 2024 earlier this year. So very excited to be hosting them this evening. At any point in time, please post any questions you've got in the chat box. You can also please feel free to just unmute and interrupt the session with any questions. We will have time for questions at the end of each talk, and we'll have a little bit of extra time at the end of all of the presentations for any extra questions that you come up with. The recording of the session this evening will be uploaded to the WFPICCS site. It usually takes about 1 week or so, you will be able to find it there in that little bit of time. We're going to kick off this evening with Ali Ferguson's session. Ali Ferguson is an advanced physiotherapist who's worked in paediatric intensive care for over 19 years. Ali is the Allied Health Lead for implementation of the PICCU STARS Liberation Strategy at the Queensland Children's Hospital. She's led the development and implementation of the early mobilisation program in PICCU at QCH, which has now been shared and implemented in many units around Australia. In 2018, Ali developed the Children's Chelsea Critical Care Physical Assessment Tool, which is a tool to measure physical function of children in critical care. Ali is the Secretary of WFPICCS Board of Directors and the Chair of WFPICCS Allied Health Committee, and she will be talking to us on optimising individualised developmental care. Thanks, Ali.
Thank you, Georgie. Hi, everyone. A big welcome from all around the world. It's wonderful to see you all here. I'm just going to share my screen, get started. Can everyone see the slides? Right. And also on behalf of the WFPICCS Allied Health Committee, Kathleen Thompson, who's the Vice Chair, and me, who's the Chair, really like to welcome you all here. And I think it's a really nice opportunity to share some of the Allied Health presentations that we presented and listened to in Cancun. So thank you for allowing me this opportunity. I'd also really like to acknowledge the contributions from the team at Queensland Children's Hospital, the Liberation and the Baby Liberation teams. It really does take a team, as I'm sure you're all very aware. So when I was approaching this individualised developmental care topic, I really thought about talking about it throughout the lifespan. We look after children from neonates to 18-year-olds, and they are all at various levels of their developmental trajectory. I'm going to set the scene, talk a little bit about brain development, look at the evidence, look at what actually constitutes individualised developmental care, the strategy at QCH, and some key takeaways. And I will try and squish it into 15 minutes, so please ask questions at the end if I go too fast. So just to initially set the scene, why do we need to think about individualised developmental care? Well, there has been, as you'll be fully aware, a real shift in focus in PICCU outcomes from mortality to survivorship. And we know that there are short and long-term effects on children who have had critical care admissions because of the iatrogenic effects of critical care. And there may be impact on neurodevelopment, maybe from the critical illness or a neurological insult, but every child's baseline is going to be really different. And on the right there, you see a number of manuscripts evaluating outcomes after pediatric critical illness and the study designs. And you'll see the exponential growth of study in the area of PICCU outcomes, which is great because it means that we really need to work out how to optimize the care we are doing during the critical illness and afterwards to ensure optimal outcomes for our patients. I'm sure you're all very familiar with the pediatric post-intensive care syndrome framework, which was first described by Joseph Manning in 2018, and it's really a familiar concept to you all probably. It embeds a developmental and family perspective, and every child and family has a really unique recovery trajectory with potential for decades of impact. We know that PICCS-P can impact on physical, cognitive, social, emotional health that persists well beyond PICCU discharge. And symptoms in these domains can really vary over time. Debbie Long and Erica Fink redefined this model in 2021 and looked at the social determinants of healthcare and how these factors interact with follow-up services and the lifetime impact. And Zara Ramati et al. then integrated PICCS-P within a bioecological theory of human development, really to provide a greater understanding of how the child fits within the intrapersonal, interpersonal, institutional, social, and community networks. And I think these models really provide a nice perspective into what we need to consider in terms of the long and short-term outcomes after critical illness. But what we do recognise is that there is a whole lot more we need to know in terms of the modifiable factors that we can change during their critical care, during their critical illness, that may have impact on their trajectory. So why are children different? Children may experience neurodevelopmental effects due to actual acquired neurological injuries or immobilisation and the iatrogenic effects of critical care. What we don't know is what the recovery trajectory is like, and it's very individual in that. But what we do know is that we really need to understand the neurodevelopment of our patients so that we can understand the potential impacts that a critical illness can have. And Debbie Long et al. Wrote this brain-directed care. I would really highly recommend it in terms of reading it. It really looks into the neuroscience principles and helps you understand why we need to look into further neurodevelopmental care. Rehabilitation and early mobility really must encompass individualised developmental care. So these are not separate things. They are very much integrated. So what are the key periods for child brain development? The early neuronal connections act as the building blocks and brain architecture for higher cognitive function. And although we know that a high proportion of our PICU patients are under the age of 5, and that's an incredibly vulnerable period for brain development, we know that brain development continues well into teenagehood and adulthood. And it's that scaffolding for executive function that is laid down in those early years. If a child has no capacity for play, then they're really at risk for less experiences. And if they have less experiences, then they have less neuronal pathways laid down and less learning occurs. So you really need to see play as the building blocks for childhood experience and brain development. While children's brains are at their most vulnerable during these critical periods, they also have the greatest potential for neuroplasticity, and by providing the neuroprotective developmental care and intervention during those periods, we really not only reduce the risk of further impact, but support learning through experience. We're also starting to learn more about the impact of adverse childhood events on neurodevelopment and physical, social, and emotional well-being. And there's recognition that critical illness may constitute an adverse childhood event. So when we're caring for these patients and for their ongoing needs in the community, providers really need to practice trauma-informed care so we have a complete picture of the child's life situation. This recent publication emphasises the importance of providing rehab through the continuum of care. So the importance of minimising distress and maximising function. So we need to start from the beginning. We start during their critical illness, but it's very important that it occurs into the school, home and community when they return home. Further studies, what do we know about children's neurodevelopment post-critical illness? So Debbie Long's study, which looked at the follow-up and neurodevelopmental outcomes after critical illness in young children, and the areas of highest concern were the gross motor and problem-solving areas. Then in 2022, looked at the neurodevelopmental outcomes in ECMO survivors and found that 1 in 4 infants undergoing ECMO in early infancy have moderate to severe neurodevelopmental impairments. And those areas are in gross motor, language. They're the most commonly affected areas. Then focusing on the cardiac population. Although we know not every individual with congenital heart disease will have a developmental delay or disorder, neurodevelopmental deficits rank among the most enduring and impactful complications faced by individuals with complex congenital heart disease. And we have the CHD Life program here of research in Queensland, and it's helping establish accessible and family-centred best practice neurodevelopmental care for children with congenital heart disease. Really emphasises a sustainable approach to developmental follow-up care and involves co-designing care models with families and health services and study partners to identify the best practice. Further study by Tomaszewski et al. Looked at the educational outcomes of school-aged children who had ICU admission before 5 years of age and found that 1 in 7 survivors failed to achieve the national minimum standard requirements, without which a student will really have difficulty making sufficient progress at school. So what is individualised developmental care? It is neuroprotective and supportive care that goes really from the neonate and infant through childhood and into adolescence, and it changes as the child grows. It's very important that the care practices are protective and supportive, and so that sensory exposure at all those ages and stages are to build experiences, which is, as I said at the beginning, the foundations for learning. And if we're not having those experiences in the critical care environment, critical care used to be full of really immobile and sedated children. Now we're having children who are more awake and able to participate in this environment. So how do we optimize individualized developmental care? So the evidence is really quite firm and bare in neonates. These practices can be extrapolated to older age groups. There's really great resources on the first 1,000 days from conception and how important those are. The figure on the right addresses the key areas of family engagement, nutrition, skin, sleep, pain, and positioning, and all addressed alongside sensory stimulation within a safe and healing environment. So developmental care really involves using care practices to improve long-term neurodevelopmental morbidity, to try and reduce morbidity. I do think that it is sometimes perceived as nice and yet optional, and it's sometimes seen as kind of like the fluffy, nice stuff. It shouldn't be seen that way, because it absolutely is providing the learning and the building blocks for these little children's brains to grow and to heal. So at QCH, we have operationalized developmental care through the PICU STARS Liberation strategy. So that is our slant on the CCM ICU collaborative strategy, the ICU liberation strategy, and it uses an interdisciplinary approach to bundled care, really translating evidence to practice. We've got the A to H bundles. So at QCH, we've added G for good nutrition and H for humanism, getting to know your patient. And that's the publication there, which we published a couple of years ago. So every element in PICU STARS Liberation is really integral to developmentally supportive care. So the bundles that manage pain, the bundles that manage delirium, nutrition, movement, and family involvement, they all are conducive and alongside promoting safe neurodevelopmental care. The key is educating the patients, the families, and the staff on how to optimize that. So a baby liberation strategy has also been developed at our site. Rona McCallendon led that alongside Tash Poole, Jane Harnischfigger, Michaela Wack, and Miranda Campbell. And they have published here in Early Human Development. So it's specifically tailored the A to H liberation bundles for use in children under the age of 6 months. It's directly in line with the NIDCAP program, which is evidence-based and well-established around the world, and was implemented here at QCH in 2020, and really aims to reduce the risk of adverse developmental outcomes. It's an individualized and cue-based use of non-pharmacological strategies to address the liberation bundles. So this is the flower that we have at the bedside for our patients, and you can see the nursing staff can work through it with the parents and find the best strategies for their infant. It's very much family-centred care with no recipe approach. I just thought it'd be nice to share some photos of individualised developmental care happening in our unit at all ages. So the key takeaways for implementation of individualised neurodevelopmental care: you really need to engage champions from the start. It's key to have champions that are across medical, nursing, and allied health, so you can get buy-in from the whole team. To educate using a variety of methods. So we educated using face-to-face workshops. We've educated using online videos. We also have a weekly newsletter, which is on the right there, which is published every Friday and emailed to all multidisciplinary staff in PICU, and it's a great way to share the success stories, but also to share information. Start small and set yourself up for success. So it's really important not to try and implement everything at once. Just try for really the low-hanging fruit, the small wins. Celebrate the wins. It's really important that staff know that what they're doing is important and that people recognize that. I think I've shared quite a lot of stories with patient consent on X, and I've done that not to say, oh, look, this is really great what we're doing, but I've done it to actually share it so that other units can realize that it is possible and it is safe and it is happening. And I think there's been a really good reaction to that. We need minimal equipment. So we're thinking non-pharmacological cares, we're thinking protecting sleep and reducing noise, and all of those things are really small changes that you can make in your unit, but you don't need equipment to do them. And really embedding across the continuum of care. So this messaging needs to also go to the ward and then onto the home. So it's essential that you educate nursing staff, medical staff and families so that they're able to continue that across the continuum. As I said, start small. So positioning, day and night routines, sensory protection, and play and cognitive stimulation. You know, it doesn't cost anything to play at an age-appropriate level. Structure your care so that the age ranges are addressed. I feel like sometimes when people think of individualised developmental care, they don't think of people that are over the age of 1 or 2. But the reality is that our brains are continuing to develop right into teenagehood, and we need to continue to give developmentally appropriate therapy to these older children as well. So where to from here? I really like this quote by Erica Fink and Scott Watson in their publication. "The ball is in our court. Let us remember the fundamentals and heal the whole child." You can see by the number of publications I've listed here, looking at short and long-term outcomes in neurodevelopmental care in PICU, that it's an area of research that people are interested in and we need to do more of so that we're able to optimise the care for our children who are surviving critical illness. So I'd like to thank you all for listening, and I'd like to say a huge thank you to the whole team at QCH and at WFPICCS, the patients, the families and staff, and of course to my family and children who put up with me doing all of these things who are at the bottom there. I've also put this slide in. So if you are not a subscriber to our WFPICCS Allied Health Network, then please click on the QR code that's there, and it'll take you to a form that you can fill out and join the network. And all that does is it just keeps you up to date with regular emails outlining our education and resources. If you need any contacts at QCH or have any questions for these individuals who've helped lead this program, then the email addresses are there, or I can send them to you afterwards. Thank you.
Thanks very much, Ali. I'll just see if there's any questions. Nothing's been posted in the chat. Does anyone have any questions for Ali? Ali, I was just going to ask one of my questions was, where do you recommend that units start with the implementation and development of these processes? But then you covered that. Thank you. But what sort of time frame do you think the development and implementation of something like this takes in the units?
Well, it requires a lot of planning before you start. So we sort of followed the implementation science process of the 4 E's, which was initially to engage, so engaging the stakeholders, educate, implement and evaluate. But I do think that initial planning phase is really important, Georgie, and you need to, at that phase, establish who your champions are, get good buy-in from the multidisciplinary team, because if you don't have buy-in from the multidisciplinary team at the beginning, then it's very hard to have success in implementation. And we are 5 years down the track now after implementation, and it does still take effort. Yes, it is business as usual, but in order to make sure that it's really optimized, it needs those little helps along all the time. Yeah, and people who are really fully committed to it.
And what are some sort of strategies that you use at QCH to kind of keep it front of mind for staff and things, for them to remember that ongoing process?
I do think we use a few different strategies. One is the bundle, which is that email, and we do celebrate the successes. So when there are, if a patient, an intubated patient is out of bed in mum's arms or playing on the floor as a toddler, those things are celebrated and acknowledged. We also have rounding, our wonderful CNC. She does rounding daily. And so she also really helps nursing staff and families to be reminded about all the non-pharmacological type cares and how they can be engaged in their child's care. And I think that helps enormously. We also have a physiotherapist who does an early mobility round a couple of times a week. And from that perspective, they of course incorporate individualized developmental care into that as well. So from several different angles, I think and the nursing staff run workshops throughout the year. There was one just this last week, and when there were there's between 10 and 20 nurses usually. We have a huge nursing staff. I think we have around like 300 nurses. So in order to be able to capture those and make sure that their education is all of a similar level in terms of implementing something, it's really important that you have some face-to-face workshops to help with that. Multiple avenues, I would say.
Awesome. Thanks, Ali.
Thanks, Georgie.
Georgie, can I just ask Ali one question, if that's okay? And you may or may not know what. And I just was more, what's your thoughts about the impacts of cardiac bypass on infants in regards to that? Because the downtime or being on a bypass machine.
Well, I think it's an area, Michele, that, there is potential there for definitely impacts on the brain that can cause developmental delay. But there are linkages there, but we can't say that all children who are on cardiac bypass are going to have that developmental delay or that impact on their brain. So I think the more we're able to follow up these children, like we're doing in the CHD Life program, the more we're going to learn about how many of these children are affected. And I think probably it's a little more than we realise, but I think it may be in the higher level functioning, and that's why it's not being captured as well. Thanks.
Great. So we'll move on to Michele Cree, who is our next speaker. Michele is recognised as an advanced practitioner in paediatric critical care and an early career researcher. Michele is undertaking a PhD where she's investigating what the optimal dosing of common antimicrobials in critically ill kids supported by extracorporeal life-saving support. And recently her systematic review manuscript was awarded the best publication of the month at the University of Queensland Centre for Clinical Research. She's a co-investigator in the RESPOND trial, which aims to improve outcomes for critically ill septic children. And she's the team lead of pharmacists in developing hospital-based strategies to improve the experience of families and patients attending PICU. Michele's going to speak to us tonight on drug dosing in PICU. One size does not fit all. Thanks, Michele.
Okay, can you see that? Can you see the screen?
Yep, looks good, Michele.
Yep, cool. No worries.
Yep.
Okay, I'm just doing that. Or do I need to?
Yes.
Yeah, cool, done. Okay. Yes, thank you, Georgie. So as we said, it's a slightly different option. We're talking about drug dosing in one size does not fit all. So firstly, I'd like to acknowledge the traditional owners of the land of which we meet today. And for me, that's the Turrbal people as the traditional custodians of Brisbane, the lands for which we work, learn and play. I'd like to pay my respects for the elders past, present and emerging. So firstly, the learning objectives of this talk were to describe the challenges with drug dosing, to describe how to dose drugs effectively, because we do want them to work, and discuss the complexities of drug dosing and PICU, because one size does not fit all, or does it? And what's next out there for future things that we should be looking at and how we would go about that. So what are our challenges? So firstly, we know that not all drugs are licensed for critically ill children, and especially for some of their diseases and conditions that they have. So there's off-label drugs, which applies for a drug that is used outside the actual official approved product license. So this would be a drug that's designated for a regulatory body like the FDA. So that means that drugs are prescribed, dispensed, administered, or taken by for another indication, or via a different route, or for a different age, sex, and again might be administered differently than what you would actually expect. So then the second part of that is we have unlicensed drugs, which is meaning that the drug itself might be licensed for children, but what we find is the actual form. So an example for that is we use clonidine tablets where we crush that and make that into a solution to give that to our children. So these are common things that we see in our PICU environments internationally around the world. So how do we actually get better options for this? Well, we certainly know that to get a license, a drug company must conduct clinical trials in the actual specified group that they want them to actually work in for that particular condition as well to make it safe. And unfortunately, that doesn't exist everywhere for every drug that we want. So we know that here, Ray looked at navigating off-label and unlicensed in paediatrics and found that majority of our medications are off-label or unlicensed. Secondly, Orleans looked at this from a WHO and basically was looking at we don't actually have oral products that exist, or if we did, some of those have also been discontinued because there's not a huge use of them in the pediatric world. So we need to think about, how do we actually dose children? So if we look at that, current dosing strategies still to this day is looking at allometric scaling. And that's looking at an adult or a linear approach. It looks where we have a parameter of weight. So we know that not all children are going to be at the same weight as we've seen. And we're using an adult dose and scaling that accordingly. That unfortunately has the potential that we won't get the right dose, because you can lead to potentially underdosing or overdosing in our children. Additionally, WHO investigated this sort of approach and basically said that this linear approach was not suitable for children, and especially for critically ill children, where that can certainly make a lot of other factors that come into play with there. So it didn't suggest another option except to look at a non-linear approach of not just body size, but to think of other factors. Unfortunately, we're not there yet, and certainly it will take time. So is there a problem with the allometric scaling? Well, certainly there is, because as we said, it relies on the body weight. For men and women are different, and certainly boys and girls are going to be different. And then it's got the potential of being a child being obese, and that's again going to have a different body weight, height, and taking into lean body weight. Some drugs where we need to actually look at dosing them lean body weight, others you might look on their actual lipid component. So it really depends on how the actual drug is metabolized. So we know this approach does not solve our problem, and because all drugs are distributed and eliminated differently, it requires on how their pharmacokinetics or the behavior. And now that can be affected by critical illness factors and certainly age developmental factors. So if we look at how do we dose drugs effectively, we need to describe the dose concentration relationship and try and look at giving the right dose, the right frequency, and the right infusion duration to get what we want to actually achieve. We also know with that, we need to take into pharmacodynamics, and that means that we're actually getting the right dose and actually producing the right effect. So for sedatives and analgesics, it's the dose that actually achieves sedation or analgesia. For antimicrobials, it's the dose that kills the pathogen. And for anti-seizure drugs, it's the dose that prevents a seizure. So it's really important to think that we don't want to give too much, but we also don't want to give too less to achieve that sort of result as well. But we want to know, like for sedatives and analgesic, as Ali was saying, we want to actually make sure that we don't give too much, so we actually are then impacting their actual brains. So now if we look at pharmacokinetics in children, over here, Fern has listed that, as I said, they're not all the same. So we know that the body composition varies significantly. There's in infants, they have a higher extracellular water, and this means it affects hydrophilic drugs, which are drugs that have generally a lower volume distribution, whilst lipophilic drugs that have a high volume distribution, are affected by a higher fat content. And this certainly occurs more likely in older children. In newborns, there's a lower protein binding of drugs, especially like for ampicillin, where there's a high free plasma concentration that results in a higher volume distribution. Drugs that are highly metabolized are administered at a lower milligram per kilo rate. And what we know there is that the enzyme differences can certainly happen. So the hepatic clearance is higher in newborns. So newborns are going to be different compared to infants, compared to adolescents and beyond. So what do we do now? So we certainly know that it takes time for the actual liver to develop, and that will actually make a difference in how we're actually going to go from there. So now looking at pharmacokinetics in critical illness or PICU. So Ferguson has this table that highlights really the problems that we can see from developmental being our part of the picture. And then we have critical illness. So critical illness is where we can actually get changes tissue distribution, which can actually result in lower albumin. Now, this can affect highly protein drugs, which means that you can lead to an increased volume distribution and a higher amount in the plasma-free concentration. So we're not actually getting the right drug for what we want to actually achieve. while fluid shifts from leaky capillaries or fluid overload from fluid boluses may lead to an increased volume distribution for hydrophilic drugs or water-soluble drugs. pH changes that occur from acute and chronic respiratory or metabolic acidosis can lead to renal dysfunction, electrolyte disturbances, and hyperperfusion, affecting the drug disposition and effectiveness. So organ dysfunction can also lead to altered volume distribution, decreased clearance for either lipophilic or hydrophilic drugs. Drugs used in PICU, such as vasoactive agents, can certainly improve the cardiac function, but it can also affect the volume distribution and clearance of lipophilic drugs. Fluid resuscitation predominantly affects the volume distribution of hydrophilic drugs. So if a patient presents with a septic illness, we're going to give them a fluid bolus for resuscitation. We're going to give them antimicrobials. We're basing it on the weight we intend the child be. Is that the right approach? Perhaps not. And then we haven't even factored in if they actually need extracorporeal therapies. So if we look here, proposed pharmacokinetic changes in ECMO and CRRT in critically ill adults was prominently done by Shkurka and a few others here. You can see here we're going to get an inflammatory response affecting the cardiac output, and that cannot certainly cause a resultant increase in clearance. That we can certainly get hemodilution or priming fluids causing larger volume distribution and causing then lower plasma concentrations and therapeutic failure. Similarly, we can get the same avenues here in renal replacement therapy, where we're going to get the drug sequestration, so it sticks to the actual circuitry, and then we're not actually getting it to the patient. Or you're getting in renal replacement therapy where actually it can be filtered off and into the waste or the effluent, which means it actually, again, is not getting to the patient. So you're getting increased clearance of some of the antimicrobials per se. So the main thing here is that not all drug dosing here are taking into account the pharmacokinetic changes to prevent suboptimal dosing and treatment failure. So here we presented a gap analysis for the pharmacokinetic studies in antimicrobial in critically ill kids. And you can see the studies in red highlighting that there's no actual pharmacokinetic studies in the antibiotics that we currently use. Unfortunately, this shows a lot of red, but it does show that some areas that we are doing pharmacokinetic studies. So yellow represents either case studies or studies that are in less than 5 patients, whilst green are actually pharmacokinetic studies that exist, while blue indicates combined neonatal and pediatric. So it wasn't clear in the studies whether there was what was the neonatal group, were they a specific option of what their distribution and clearance is here. But what it does highlight is that more work needs to be done. So if we look at tactics now, and what we're looking at here to help and assist pharmacokinetic studies in critically ill children. So we firstly have the OPTIC study. Now their primary objective was to actually characterize pharmacokinetic studies and the pharmacodynamics of the drugs of interest. And what they looked at here were primary endpoints, looking at pain scores, laboratory values, like looking at an electronic database to see what you could actually get from the clinical systems, to provide a mechanism to really trying to decrease the actual burden and provide high efficiency trials and support drug development in certainly historically understudied population, which we know our patients are. So then Tang looked here at the feasibility opportunities, looking at opportunistic sampling using scavenging of residual blood for future pharmacokinetic studies. So what they did was look at cefepime, meropenem, and piperacillin. It was a single centre study, and they certainly found out that you could actually look at this strategy, and sort of looked at this over a 2-week period and found that certainly for the 3 antibiotics that they looked, that the drug dosing and looking at the scavenging, that they didn't find that the same sample points were taken at the same time, and that allowed them to actually provide what the distribution and clearance in those children were. It could be something that, and it is something that we have adopted in a clinical study that I am conducting. But they did find that there was some degradation which did occur for meropenem and piperacillin at a 15%. This is mainly because it's not actually stored in a form that could be in -80 or a bit better option. So it might be that we have to look at how do we actually get some of these samples earlier, and it certainly may be an option that we could look at for future. Additionally, you can see that a lot of these options here, HAVI was involved in the development and the validation of using cefotaxime and doing blood spotting and microsampling, and certainly that's something that could be for the future, because we're looking at a spot to actually produce a level which would certainly decrease the blood sampling volume. So how do we dose critically ill children? Well, currently we look at specific targets and goals. So firstly, we look at our neurologically, looking at sedation, so the Richmond agitation sedation scoring, aiming that intensivists will provide us a goal, tell us which way we're going, and aiming for our patients. And we try and strive that every day with the individual nursing focusing on that. For pain, we have a flat score. We use one universal score right throughout. Even though it's not validated for the under 6 months, it was just easier to do one score. Withdrawal, we're using the withdrawal assessment tool to actually assess for withdrawal, and the CAPD looking for the delirium. So for cardiovascular, we've got MAP targets, heart rate, and we have an ability to focus on those, and we would do that daily. Respiratory, we've got your saturations, pH, and looking at what we're aiming for there. Fluid allowances, we would actually have an hourly fluid balance. We would also look at an overall daily fluid balance, so we know what we're actually striving for. For temperature and arterial blood gases is certainly something that we can do easily in the ICU. And then there's also the use of therapeutic drug monitoring. So here we have looking at therapeutic drug monitoring, where you might actually look at, you have guidelines production of what and product information about how we would actually give that dose. So you come up with your initial dose, which may be based on milligram per kilo, and then you would actually unfortunately have to wait for steady state. Now, steady state can vary in every drug. In some antibiotics, it can be after the 5th dose. It can be after a week in some other drugs. So we'd have to wait, hoping that we didn't cause toxicity for that patient, or we didn't cause underdosing if we're actually trying to kill a pathogen or a bacteria. And then we'd take our drug sample. Generally would be either a pre-dose, or it could be that we're looking at a pre and post, depending on how the kinetics and distribution of the drug is. And then we'd look at what that drug concentration is, get a comparison, and then do a nominated, educated clinical guess about what dose change we would do, and then start the whole process. Certainly not the best approach, but that's all we've been able to do for the last several years. Certainly what we need to look at is looking at futuristic options, is looking at a model-informed precision dosing, where you might actually factor in an actual model with an MIC, meaning the minimum inhibitory concentration you might want for an antibiotic, what is to actually kill that pathogen. You might come up with that. Look at what are the models that have come up and what are the actual clinical covariates that actually helps determine the models. Is it male, sex, height, weight, the kidney function, or the liver, whatever that is. It could be extra settings, it could be actual blood flow rates. Come up with an initial dose. Then we don't have to wait for steady state. We then get an antimicrobial plasma concentration. We can look at Bayesian pharmacokinetic estimation, which is what we are doing over here. And that basically will say, well, we want to get above this result. How do we actually get there from that point? By plugging the data into a model and coming up with a dose simulation where we can get individual pharmacokinetic parameters and achieve that target. So it allows us to do that change. So a colleague of mine, Quinn 2, has been looking at this and validating in the critically ill child. And certainly that's something that we are striving for, and maybe looking at that for the beta-lactams in the future. So looking at the future therapeutic drug monitoring, this can be certainly aiming that it will be bedside. It won't need to have to go off to a pathology result. That would be my future option, is you can do that continuous monitoring right there and now. We can actually see what's happening, look at biosensors, real-time assaying. Then we're going to have artificial intelligence producing our data analysis and exposure prediction. That's generally based on our models and the type of patients that we're seeing. We're going to get model-informed precision dosing software, which we are working on for the future as well as part of our academic component, and then looking at dosing adjustments and then going around there. Again, very much reliant on us developing the actual pharmacokinetic models to move forward in the future. But certainly something that we're striving for to make sure that we actually get the right dose for the children. So in summary, pharmacokinetic studies are vital in understanding drug distribution and clearance. Drug dosing and response studies in critically ill children are required, and the industry, we really need the companies to actually support studies in critically ill children to make sure that we actually have the right dose and interval for them. Individualizing therapies and using AI certainly will assist drug dosing in the future. And these are some of the problems and some of the things that we can see here. Any questions?
In the interest of time, probably only have time for one question. Does anyone have anything for Michele? Michele, I just had a quick question. From an ethics perspective, and even to get buy-in from various intensivists who obviously have their own sort of biases towards certain drugs, is it tricky to get studies across the line from a pharmaceutical studies?
Yeah, so certainly drug companies do throw a lot of money in children in that sort of aspect to actually get studies and getting consent. Again, it's understanding what is required, but pharmacokinetic studies and basically doing that requires multiple samples. So it's over a dose and an interval. So for example, if we're giving a drug that's given every 6 hours, then I might want to, if I'm taking sampling, which we're currently doing for several antibiotics, we take a pre-dose and then we take multiple doses before they have their next dose. So the problem is a lot of these things in critically ill children, it's easier because we've got arterial and sampling lines to take blood samples. But in your child that's on the ward, it's a lot more invasive. But certainly if we can, ways that we can minimize taking less blood, looking at microsampling certainly will be very much our future.
Thanks, Michele. Our last session this evening is Emma Shkurka. She is a clinical academic physiotherapist working as a specialist pediatric critical care physio based on the cardiac intensive care unit at Great Ormond Street Hospital for Children, the NHS Foundation and Trust in the UK. She's an honorary research fellow at the University College London. Her PhD was a mixed method study investigating the safety profile of respiratory physiotherapy in mechanically ventilated children. Other research interests include early mobilisation and rehabilitation, physiotherapy for patients receiving ECMO, and physiotherapy-led point-of-care ultrasound. Emma's going to speak to us this evening on early rehabilitation and mobilisation on ECMO, friend or enemy. Thanks, Emma.
Thanks, Georgie. Can you see my slides rather than the other pages? Yeah, my slides look okay?
Yeah.
Yeah, perfect. Okay. Great. So thank you, Georgie, for the introduction, and thanks to Ali and Michele for the previous talks. So I've been asked to talk about early rehabilitation and mobilisation, so an area that I am really passionate about, and hopefully this will lead on nicely, especially from Ali's talk, just thinking a little bit more specifically about the ECMO population. So I have no conflicts of interest. So it's quite a dramatic title, sort of friend or enemy, but really how I'm going to approach this is think about early mobilisation in this population from a risks versus benefits perspective. Ali's really nicely talked about the sort of A to H bundle, and I'm just going to start by giving a few more specific definitions around early rehabilitation and mobilisation. I think there's lots of sort of interchangeable terms, and within the UK since the permit study, we've moved sort of more towards using early rehabilitation and mobilisation as a concept. Apologies, I've just been plunged into darkness, but never mind. So really on the screen, you can see at the top that we have the definition of early mobilisation. So this is neurodevelopmentally appropriate increasing mobility levels. So this is a nice definition because it is quite pediatric and child specific, because it talks about it being developmentally appropriate. But as sort of Ali's alluded to, it's a much bigger concept than just thinking about the moving element. So I always like to show the definition which follows of rehabilitation. And you can see that this talks about helping a person to be as independent in sort of everyday activities. So thinking about education, recreation, and meaningful life roles. So this really, I think, brings to the forefront that holistic approach and actually how many sort of different components there are to this concept. And then what do we mean by early? So if we look at Chong et al.'s definition, they talk about early mobilization being considered within 24 hours of admission. So I think especially in the ECMO population, this isn't saying, okay, all ECMO patients need to be up and moving within 24 hours of being admitted. What it indicates is that actually this needs to be part of the conversation within the first 24 hours of admission. So just to give some examples, and Ali's already shown some lovely examples in her presentation, you can see from this slide that early rehabilitation and mobilization is a whole spectrum of interventions. And again, this is encompassing the whole sort of A to H bundle. I think it's key to say from a ECMO perspective that not all children are going to be aiming for those really high level activities. And actually in the ECMO population, some of these more subtle, perhaps more day-to-day type interventions can have a real impact. So you can see, I mean, we've got those sort of more mobility activity related ones, such as exercises, cycling, sitting. And then we've got others involving family and siblings, communication, play, school. We really like pet therapy. So we like it when this is Dr. Ted. He often comes to visit and wears a variety of different outfits, which is super cute. To put this just into context even further for the ECMO population, so we published in the UK a guidance document, so a sort of consensus-based document. And like some of the other early mobilization programs available, we came up with a selection of activities based on sort of the acuity or the sickness level of the child. Now, these are not an exhaustive list, but it gives the MDT examples of the different types of interventions that can be completed with different types of ECMO patients. And I think something which actually I didn't mention on the other slide, but I think that slide and then this range of activities really helps to highlight is that actually it is an MDT approach, and your centre does need to have access to all the different specialties and therapists to enable you to successfully implement these sorts of programs. So that's a little bit of background. Thinking about the evidence, and to start with thinking about feasibility. So there are some published studies thinking about the feasibility and practicalities of early rehabilitation and mobilization, or awake ECMO. So on the screen, you can see there are 3 studies, and these are all single center studies. The first study by Costa and colleagues looked at, I think it was 8 neonates who were awake and extubated during their time on ECMO. They were actually extubated because of respiratory reasons, sort of air leaks. They didn't want them positively pressure ventilated. And they were a whole range of VA, VV type ECMO diagnosis, so meconium aspiration, PPHN, congenital diaphragmatic hernia. So all these children were able to be safely extubated whilst on ECMO. The second paper involved 6 patients on VA ECMO who were extubated. 4 of them were under 1 and 2 of them were sort of teenagers. A median or mean time of extubation of these patients was 78% of their total ECMO run. So quite a high percentage of their time on ECMO was extubated. They were able to complete daily active and passive exercises. Parents were involved in feeding, washing, cares, etc. And then the final study on this page involved 16 patients, and this was a retrospective study and included patients who were extubated for more than 24 hours. And in this study, the mean extubated time was 43% of the ECMO run. These children had reduced sedation requirements and increased opportunity to avoid deconditioning. I wanted just to highlight, I think, 2 of the key papers from the last few years. And I think this paper by Edelson actually probably is the most important paper in the field. And this was a ELSO registry study which looked at specifically children who had a primary run of VA ECMO. It only included children over 8 years of age, and this is because actually the registry data that is collected regarding mobility is only for children over 8, and they used a maximum mobility score. So the ELSO registry asks centres for each patient to put down a score between 0 and 10 of their mobility level, I think at day 7 of ECMO, and then at the sort of the maximum score they had in their whole ECMO run. Just to give you some context, sort of 0 is doing absolutely nothing, 1 is sort of sitting in bed or doing exercises in bed, 4 is standing, and then I think 10 is complete independent walking. So the authors stratified that scoring system. So they created 2 groups, basically. A group of patients that had scored 0, so they did absolutely nothing, and then everyone else they clumped together as someone who did some mobility. So I think already one of the things to highlight is actually that's quite a broad group. So some children perhaps just doing exercises in bed, others doing walking around. So in their time period, which was really the whole time period that this data has been collected by ELSO, they had 688 patients, and actually so 69% of those, so 10% achieved some mobility. And then a second study from this year is a systematic review and meta-analysis, which looked at this concept of awake ECMO, which looks at being extubated, obviously being awake, but also being able to participate in physiotherapy. So the authors found 19 studies which equated to 65 patients, and of these 66% were able to be extubated at some point in their ECMO run, 18 had a tracheostomy, and physiotherapy, so activity, exercises, was able to be completed in 97%. So I think we know this is feasible in some patients. There's very little specific guidance from ELSO around early mobilisation. 2 of the current guidelines, one related to respiratory patients and one cardiac patients, do mention around sort of concepts of early rehabilitation and mobilisation. So you can see there are suggestions that being extubated is an option to consider, and that actually we want to minimize sedation. The cardiac failure guideline gives a little bit more detail. So awake ECMO can be considered in a select group of children, so those with peripheral ECMO, where the circuit's good, they have a closed chest, for example. This also highlights, as I've mentioned earlier, around really that MDT approach, and again, the importance of sedation and a protocolized management. So let's go back then to think about the whole sort of aim of this presentation, that friend versus enemy and those benefits versus risks. So if we look then at the evidence from a benefit perspective, the 3 single center reported very descriptive type benefits. So that children in the Costa trial were able to feed orally, they were able to have meaningful family interaction, which if we think from a neonatal, from a newborn perspective is really important. And then in the other studies with the slightly older children, they were able to improve their physical condition, had reduced sedation requirements. I think a key thing on ECMO, given the high risk or increased risk of neurological injury, is that actually having a child awake allows you to more accurately assess their neurological status. Then looking at the Edison paper, so I think the first thing to highlight here is that because it was a registry sort of retrospective study, there's no sort of causal inference with these results. However, if you can see on the slide, they did conclude that there was an increased likelihood of being discharged alive or receiving a heart transplant in the group that mobilized, and actually a lower likelihood of dying. So this is starting to show that the potential advantages of having children awake and mobile on ECMO. To look then at the converse, if we think a little bit about the risks, and just to present briefly some results from an European sort of survey of ECMO practice. So this looked at, had responses from 12 countries and 33 centres. And when we asked centres around their sort of perceived risks and barriers to early mobilisation and rehabilitation of ECMO patients, the key concerns were around sort of cannula dislodgement, safety of the circuit, and also patient stability. Other issues were confidence and competence of the healthcare professionals. So in paediatrics, this is a relatively small specialised population. Perhaps actually the numbers of children that are appropriate aren't that frequent. So how do trusts and teams build their confidence and competence in this area? And then finally, sedation and delirium was also thought to be a barrier. So linking this to the evidence, actually of those single centre case studies, Costa and Anton Martin reported no adverse events or complications related to being awake. In the Schmidt study with 6 patients, they reported no life-threatening complications. However, there was one cannula dislodgement that did require surgical intervention. So I will leave you to determine how significant you feel that is. And then the other 2 studies, so in the meta-analysis, there were a high rate of complications reported in the patients in that study. But again, these weren't specifically related or attributed to being awake or mobile, because what we don't have is the complication rate to compare in the other children that weren't mobile. In the Edelson, and I think paper, and I think this is reassuring, there were no statistically significant differences from a safety perspective between that group who mobilized and the group that didn't mobilize. So to sort of conclude then, do we think early rehabilitation and mobilization in ECMO patients is our friend or our enemy? I think from the data that I've presented, and I suppose my personal opinion, I think it is our friend, but I think this comes with some caveats and some considerations. So I think it is feasible and achievable in a sort of carefully selected patient group. So to conclude, as Ali highlighted, this approach needs to be very much individualized. And this is not only to the acuity and clinical status of the patient, but also then the activities and the approach that we're completing. I think it's important to have sort of protocols and guidelines with regards to safety and risk assessment, especially if we're completing higher level activities with our ECMO patients. It's imperative that we have everyone in the MDT involved, and also the family play a really important role. I think thinking from a future perspective, we need some prospective investigation really into the efficacy and safety. And I think this will then help sort of the wider MDT and other sort of centres where this perhaps isn't as routine practice really have the confidence to start these sorts of interventions. Perfect. So yeah, any questions? I will stop sharing.
I have one, Emma.
Yeah.
If I can ask.
Of course.
In regards to, like with ECMO, we know that sedation and analgesics are sequestered. Do you have a sedation and analgesic coming off ECMO guideline?
So do you mean for weaning off, or do you mean for when we are trying to do these activities?
What I'm probably thinking is when you're weaning to get off ECMO specifically, because we know that half the drug's going to be stuck in the circuit, so giving them the same doses is probably going to over-sedate.
Yes. I think for us, we just tend to go on the comfort score from our sedation perspective, and that's what we would base a lot of our activities on. So we will have them awake and sort of comfortable based on comfort scoring related to their clinical severity. However, when we start to wean off in that sort of process of it depending how unstable they are, we would then obviously resedate them. But again, it depends. We would, again, once they're decannulated, we would try to get that sedation off as soon as possible. But I think a lot of that is very patient specific and related to their clinical condition, to whether actually we would then wake them up very quickly. So as far as I'm aware, we don't have a specific protocol sedation once they're off ECMO. That would be based on sort of our usual PICU care.
I have a question for you, Emma. Thank you so much. It was a great talk. You have obviously done a lot of work in this area and are really knowledgeable. How do you recommend, or how did you change the culture in your unit from sort of just doing passive ranging when patients are on ECMO to then escalating the levels of activity? And what sort of advice would you give to people watching as to how do you approach this in the first place?
Yeah, thanks, Ali. I think, that is the big challenge, and we are by no means where we want to be, but we have, I think, seen an improvement over the last few years. So I think the first thing is the sort of promoting the role of the therapists on the unit. So I think it's about your relationships with your MDT and your ECMO specialist. So I think it's about that respect, and also having those sorts of relationships where you can suggest things and that's taken seriously, and then it's a sort of an open discussion. So I think one of the parts comes down to your MDT team on your unit, and actually how well and how open that is to taking other people's opinions on board and suggestions. I think what's really helped for us is, so we launched our sort of Gosh Go, which is our generic across ICUs early rehabilitation program. And we also did a Gosh Go ECMO. And I think that in conjunction with the consensus document, because actually in there are some sort of guidelines, and we use the sort of bedside risk assessment routinely when we're doing any sort of higher level activities. So I think having something tangible that you can take to consultants or your ECMO specialist and say, actually, this is what the guidance says, this is the process that we're going to follow, this is how we're ensuring safety and risk assessment. So I think having something tangible that they can see, sharing those sorts of documents with your team. And then I think it's about celebrating the successes, and you talked a lot about this. So I think and I think one of the biggest challenges in ECMO and even at our centre is there is a big cohort of our patients that are not appropriate for anything much more than in-bed activities. And I think we maybe have, I don't know, we'll have one patient every few months. And actually, it's how does your team maintain that confidence and that competence? Because almost like it's starting again almost every time. So I think it's really celebrating when you have done something, you've achieved something really well, to remind people, and also celebrating that wide across the unit as well. So actually people being like, oh no, we did sit that patient up and actually it went really well and they decannulated and then they were really sort of had good activity levels quite quickly post decannulation. So I think that really helps with the confidence and getting people on board. But I do appreciate it's that first few times is really the difficult thing to initiate. But again, like you said, starting small, use maybe a bed bike or even just having the patient awake and interacting. And I think using each other, using this network, and actually from an AHP perspective, having people that we can, I don't know, troubleshoot with, or in your country having where we can do sort of reciprocal visits, for example.
Yeah, I totally agree with you, Emma. I think safety, making the team at the bedside feel safe is such an important step to be able to go forwards, isn't it? And we're very similar in our unit. We have had some successes, but the patients that are appropriate for higher level activities are so few and far between that you have to dine out on the successes for quite a long time. But you know, we're constantly looking for that next patient to be able to do that with again, so that again you're building that trust, you're building the safety profile, and we're enabling. So yeah, thank you.
Emma, I have a question for you. I wondered if you could share who your most potentially risky patient was that you successfully mobilised. Has there been one that people were like, oh, we're not sure, and you kind of, you know, worked on it a little bit and got the team around and were able to have a good news story?
So we had so there's two, and I suppose it's different things. So we had recently, well, no, yeah, probably in the last 6 months, we had an older girl who, so we don't often have femoral cannula. We often just use peripheral neck cannulation. And we had an older teenage girl who was a cardiac patient on VA ECMO who had a femoral cannula, and the surgeons weren't happy with us bending the hip above about 45 degrees. We'd extubated her, so she was awake, she was very compliant. But actually thinking from sort of a strength and gross motor perspective, the biggest challenge, we were like, well, actually, we couldn't sit her more than 45 in the bed. So we were sort of really problem solving. She was obviously really awake, wanted to do stuff, was really bored. So that took a lot of sort of problem solving, and also problem solving, I think, with the surgeons and the ECMO specialists about, okay, well, what activity could we do with this sort of restriction? And actually in the end we tilt tabled her, so we pat slided over onto a tilt table and then did some work in the tilt table, just one to get her obviously weight bearing, she really to work on upper trunk control. But I think there was a lot of nervousness around the cannula and the fact that we couldn't flex the knee and how would it cope, and actually inevitably it went very well, and she was and really enjoyed it. So I think that was more from a problem solving perspective around, okay, what can we do with this limitation? And then we had another very weak girl who's got a myopathy. And we did a sit over the edge of the bed. And I think given the really, really low tone and sort of lack of any sort of muscle activity, actually the sitting over and being able to support the cannula and the head. But really how we got around those was we use it from the document, and I can share in the chat, or Ali can share over email, the bedside risk checklist. It's almost like a pre-brief and a debrief. So we stop everything before we start, we allocate jobs, we know what our key parameters that we're concerned about with that individual patient are. So I think it's about that confidence instilling in the group and in the team, basically.
Excellent. I really liked the activity levels that you had in the sort of red, orange and green. We've got something similar that we use in our sort of liberation allocation of activities, but it's nice to have something that is specifically written as appropriate for ECMO patients, I think. Is that activity levels, are they allocated by the doctors daily, or who decides what activity levels?
So that would be whoever's really leading, but the whole team basically. So I think that links to their acuity level, which again has a similar red, amber, green. But depending on where we think they are in their acuity, so let's say, I don't know, if they're centrally cannulated with an open chest, they'd be in the red. If they were peripheral VV and they're comfort score was between, I can't remember off the top of my head, whatever the category is. So I think, to be honest, I think that's more of perhaps a medical and an ECMO specialist and rehab led decision. And then it would be down to whoever is completing the ERM. So we've designed that actually the nurse could look at it, and if the nurse knows they're in amber, actually she can look and say, okay, well, these are some of the activities that are related to nursing, or whichever therapist it is. So we at our centre do it much more as an MDT, but in conjunction obviously with surgeon and ECMO specialists. We have just done a qualitative study, actually a review of the document, and actually one of the things that's come out of it is actually people would like it to be a little bit more specific to age appropriate. So that's something we might work on the document and sort of update, is making those activity levels a bit more age or developmental level appropriate.
Excellent. Thanks, Emma. Does anyone else have any last questions for any of our presenters, Ali, Michele, or Emma? Thanks, everyone. Ali's just popped in the chat the QR code. So if anyone would like to join the WFPICCS Allied Health Network or to share it around with your colleagues, please do so. Remember, the recording will be uploaded onto the WFPICCS website, and Ali will share around any resources and things that Emma has mentioned in her talk as well. Thanks, everyone. Have a good evening.
Thank you, everyone. Thank you for hosting, Georgie.